Hello, everyone. Good morning, good afternoon, good evening, wherever you may be. Welcome. I'm just going to give it a few minutes so that everyone can trickle in until the numbers stabilize. Okay, I think we can slowly get started. Welcome everyone to our virtual audience to this UHC Day 2022, UHC for Rare Diseases, Developing Key Pillars Together. We are very happy and delighted that you will join us in celebrating UHC Day together this year. My name is Dolores. I am Rare Diseases International's Public Affairs Manager, and it's an honor to be here with all of you. I want to just cover a few housekeeping points before I give it over to Mr. Todd Howland from the OHCHR to formally open this event. So we're very delighted that this event is actually being translated into Spanish. So you have two ways to be able to see those Spanish closed captioning. The first way is to look at the bottom of your screen. In the bottom ribbon, you should have a button which says either CC, so closed captioning, or show captions. If you click on that button, you should be able to see what I'm saying translated into Spanish. It might also be under a live transcription button or under a more button. You can also see the Spanish translation and actually also an English closed captioning in a separate screen. So if you click on the link that will be shared in the chat or has already been shared, you can see that, or you can take out your mobile phone and just scan the QR code that's on the screen right now, and I'll leave it for a few seconds. Okay, so without further ado, I would like to introduce our first speaker who will welcome all of you and formally open the event, Mr. Todd Howland, who is the Chief of the Development and Economic and Social Issues Branch at the Office of the High Commissioner for Human Rights. We are very honored that they are actually co-organizing this event alongside Rare Diseases International, the NGO Committee for Rare Diseases, UHC 2030, and the Civil Society Engagement Mechanism. Mr. Howland, over to you. Thank you so much.
Thank you, Dolores. Distinguished colleagues, ladies and gentlemen, a warm welcome to you to this event to commemorate Universal Health Coverage Day. I want to thank Rare Diseases International and the other co-sponsors of the event today for the invitation. Today, we are also beginning a year-long commemoration of the Universal Declaration of Human Rights to celebrate its 75th anniversary. But in some ways, there's not a lot to celebrate. The vision of the Universal Declaration for Human Rights was for everyone to live free of fear and want. The reality of people living with rare diseases demonstrates how all too often economic, social, and cultural rights were considered somehow optional, and that economic and power factors considered more important. We need to rekindle the letter and spirit of the Universal Declaration of Human Rights to create economies that work for people and planet, where human rights serve as useful guardrails for economic policies and systems. The Office of the High Commissioner for Human Rights reiterates its solidarity with you and with all stakeholders in your efforts to secure universal health coverage for persons living with rare diseases. Human rights are critical to creating health systems that produce prompt diagnosis and treatment related to rare diseases, as current investments are often inefficient and duplicative, as research is motivated more by the greatest return on investment than related to people. Human rights standards pertaining to the right to health and to all rights which affect our health and well-being are well established. We have the International Covenant on Economic, Social, and Cultural Rights, the Convention on the Rights of the Child, and the Covenant on the Rights of Persons with Disabilities. We also have political commitments, such as the 2030 Agenda for Sustainable Development and the Political Declaration on Universal Health Coverage from 2019, where the vast majority of states reaffirmed their commitment to universal health coverage. And in a significant boost to all of your advocacy efforts, the General Assembly adopted a resolution last year on the challenges of persons living with rare disease and their families. But we need to use these legal frameworks and political commitments to change our reality. Universal health coverage is an important dimension to the right to health. It includes enabling conditions such as access to safe, effective, quality, and affordable essential therapies, medicines, and diagnostics for all. These remains a challenge given the inadequate investment into research and development in the area of rare diseases. Millions of people living with rare diseases face almost insurmountable challenges due, among other things, the lack of expertise in rare conditions, which in turn often makes diagnosis a complex, lengthy, and costly process. Why? Part of the answer is there's simply not enough political will to address this issue with the focus and urgency that is needed. The Leave No Behind principle, espoused in the 2030 Agenda for Sustainable Development, which calls for inclusion and participation, is yet to be felt by most of the 400 million or so persons living with rare diseases. And so much remains to be done to bring needed change, and your advocacy is critical. Before I hand over to the next speaker, I would like to leave our stakeholders, particularly states, who are the primary duty bearers, with some recommendations. 1, invest meaningfully in research and development and in health services for people living with rare diseases. 2, evaluate whether your current system conforms to your human rights obligations. 3, include universal health coverage in your legal and policy frameworks. 5, ensure that persons living with rare diseases participate meaningfully in making of the policies around universal health coverage, especially in relation to the setting of priorities. 6, in the context of rare diseases, establish mechanisms for the exchange of technical know-how and the training of physicians and other health personnel to improve their ability and work with diagnostics. And finally, treat human rights as part of the rule of law, as economic, social, and cultural rights, obviously including the right to health, are not optional. Thank you for your kind attention, and more so for the work you're doing to help realize the right to health for people living with rare diseases. Thank you.
Thank you so very much, Mr. Howland. I think if we were in person, you'd be hearing a round of applause right now. That is really, really wonderful. And I think pretty much the perfect opening to this session. You've kind of pre-shadowed everything that we're going to speak about for the next hour and a half. Okay, so with that, I'd like to pass it over to our keynote speaker, Dr. Surakamet Mahashiri Mongol. I've had the pleasure of hearing bits of his presentation in person, and now he is going to share it virtually with all of you. Dr. Mahashiri Mongol, who insists I call him Surakamith, is the director of the Genomics, Medicine and Innovation Support Institute at the Ministry of Public Health in Thailand, who, I remind you, was actually a co-sponsoring country of the UN resolution, which Mr. Howland mentioned, now nearly exactly 1 year old. So without further ado, Surakamith, please, the floor is yours. Thank you. Just don't forget to unmute yourself. Yes.
Okay. Thank you very much, Dolores. I would like to thank the Rare Disease International and all the co-organizers that arranged this meeting and invited me to speak in this event. So I will try to spend 5 to 10 minutes to deliver the keynote remark. This is the Ministry of Public Health. I am from the Medical Life Science Institute at the Department of Medical Science in the Ministry of Public Health. The picture here is the institute that I work every day. And I just want to remind everyone that we had the UN Declaration on Universal Health Coverage that was endorsed on 10th October 2019, and the focus is on strengthening efforts to address rare disease. Thailand is also one of the countries that support this declaration. A short information for Thailand. Thailand is in Southeast Asia. We have 68 million population, and we have around $6,000 GDP per capita in 2016. So we are upper middle income country. And right now we have life expectancy at birth at 75. So you can have the basics information about the health system in Thailand. Currently, the universal health coverage is covering almost all Thai population. We have 3 big health insurance schemes. The first one is Civil Servant Medical Benefit Scheme, covering all civil servants. This is started in 1980. And then we have Social Health Insurance Scheme for Social Security Act in 1990. This is supporting all the labor running by the Ministry of Labor. And the last one is the Universal Health Coverage Scheme. This is covering 48 million of 68 million population. So by these 3 health insurance schemes, we cover almost everyone in Thailand. The finance is also supporting by the health delivery system. Thailand has the district hospitals, which is covering 30,000 to 50,000 people. At that district hospital, we have doctor and nurse and paramedic. And we have also health center, which is covering around 3,000 to 5,000 people. This is primary healthcare system in Thailand. All of this is running by the Ministry of Public Health, which is established in 1942. So we are almost 80 years already. In 1990, all district has at least 1 hospital, and in 2000, all health center is fully covered in the country. So this is the picture of location of the health center, district hospital, and secondary and tertiary hospitals. All of this is under the Ministry of Public Health. So we are delivering 70% to 80% of healthcare service in Thailand. For the UHC coverage index, we had 41 UHC coverage index in 2000, and now we reach 83 point. So this is the current status. Within 20 years, we have fully implement the UHC service coverage across Thailand. For the maternal and child healthcare, we have 5 benefit package. And the first one is thalassemia screening. Second is Down syndrome screening. And we have the newborn screening, which is focusing on 2 diseases, and HIV newborn screening. And the last one is inborn error metabolism, which is just established in 2022. This newborn screening was established for already 37 years, but we just, for the first 36 years, we focus on only 2 diseases, mainly because we could not provide the care for the inborn error metabolism before 2022. The service package for treatment of this inborn error metabolism just established recently. So this year we start screening of 24 inborn error metabolism in Thailand under UHC program. And this is the work that we did in the last 36 years. And we identify the congenital hypothyroid case and the phenylketonuria case. And we established the incidence of these 2 diseases in Thailand based on the 20 million newborn screens in the past. The system is involving the hospitals and the logistics system and the laboratory system. So these 3 parts working together to deliver a sample from newborn at the hospital to the laboratory and send the result back to the hospital. This is the rough idea how it works. So we monitoring the progress of logistics from each province in Thailand. And we also have the information system that monitoring all the steps in Thailand and return result back to the hospitals. The Deputy Prime Minister, Mr. Anutin, and the Deputy Health Minister announced this year that we had the benefit for inborn error metabolism. And this is also cover all the rare disease cases identified from inborn error metabolism. The treatment and the milk for these children will be supported. Also the transport cost from the local area to the tertiary center to see clinical geneticists will be supported also. Within 2 years, we hope that we will implement all these programs fully in Thailand. This is the result of communication within Thailand. We go to the health district area and we discuss with pediatricians, nurses, medical technologists, scientists in the region, communicating the program implementation and discuss how to improve the program implementation. We hope that we will be able to deliver the IEM screening within 7 days for every newborn. This is the target that we hope to achieve. And we also collect this goodly card for biobank. The biobank is open for research. This is also part of the Genomics Thailand, which we plan to sequence the rare disease for 10,000 children. So those children will be able to access to whole genome sequence data through research. And this is the new information system that we are establishing. We hope that we will be able to deliver the result back to the mobile phone of the patients at the local level. So those are the current situation, and I hope that with this information, this is the starting point for discussion of how we can strengthen the effectiveness of national, regional, and international policy development program related to persons living with a rare disease. Thank you very much.
Thank you so much, Sudhakama. Thank you very, very much for this super informative presentation. And it's an honor that you are here to give the keynote address. And again, everyone's kind of foreshadowing what we're going to speak about for the rest of the session. So I found this point about mobile health and having the result actually come directly to the local level extremely interesting. So I can see before we move on to our next speaker, I can see that my colleague Laulani is putting a few reminders in the chat that I can just echo. So please, if you haven't done so already, feel free to introduce yourself and perhaps the organization you're presenting in the chat. You can turn on the closed captioning if you go to the bottom of your screen, so clicking on CC or live transcription, or you can click on the link that's being shared and you can get a transcript in English or Spanish. We should have some time for questions and answers in around half an hour or so, so please do put your questions in the chat and we'll keep an eye on them and address them a little bit later on. Okay, so moving on now, we're very honored to have, I think we can call CSEM, or the Civil Society Engagement Mechanism for UHC 2030, our friends. So we have Smitha Sadasivan from CSEM and from UHC 2030, from the steering committee of UHC 2030, who is going to speak to us a little bit about financing UHC for persons living with a rare disease. So Smitha, please take it away. Thank you.
Thank you very much. So yeah, I'm from the Civil Society Engagement Mechanism for UHC 2030. We are the Civil Society constituency for UHC 2030, and CSEM facilitates voices of civil societies across the world to ensure UHC policies are inclusive and equitable. We work with around 1,000+ organizations, and we believe that civil societies have a vital role to play in achieving UHC for all. And I would like to touch upon 4 aspects. We have the chief from the OHCHR here, and so I would start with human rights and then move on to policies and implementation advocacy and suggestions for financing. So with regard to human rights, it is very close to my heart as I am a disability rights activist, a person with rare disease myself, and a person living with disability. So we have the Universal Declaration of Human Rights, which was mentioned just now. And Article 25 is talking about the right to standard of adequate health and well-being, and it is not stopping there. It is also talking about social services and social security. So what does that mean? Just health alone is not adequate enough. Along with health services, health rights, there should be provisions of facilitating social participation through social services, and which is also uttered by the CRPD, the Convention on the Rights of Persons with Disabilities. It gives a very beautiful definition, like when the impairment in the body or a health condition in the body, it interacts with the barriers in the environment, that is when a disability happens. So when we see a lot of people with rare diseases who have invisible disabilities, who are not able to participate because of the barriers, because of the health barriers, or because of the social participation barriers. So everybody would come into this frame, and that is very beautiful about that definition of disability in the UN Convention. And it is not stopping there. It is also talking about every human right from the barrier approach and from the support system approach. And when we say support system, we think that generally like people with rare diseases or people with any issue or any condition need support and not others. Whereas support system is for everyone. Everyone requires support system, and it is available to everyone in the community. Like for example, the schools, the education system, or the transport system is all a support system. Why? Because education is a right, transport is a right, and it should not be curtailed or it should not be lagged for anyone. That is why we it is all the support systems come along with the rights. And so when we look at people with disabilities or people with rare diseases, there is a need for a little bit extra support. And yes, we have those needs, but that also become our right. So that is what the CRPD says, that any support system required for a person with disability or a specific condition to participate in the society on an equal basis with others, it becomes the right. So we have to look at the health policy from that angle, because without health there is nothing. Like any right comes starting from health. If you don't have health, you cannot exercise your right to education, you cannot exercise your right to movement, you cannot exercise your right to leisure, your political participation, or right to livelihood. So the crux of all the rights is health, and from that angle we have to look at the health aspect, health for all. And it is not like health for certain people is has higher needs, and certain people it is a comparison. No, it is never a comparison. Every person's health requirement is a right, and it has to be met. And that is why we have all these SDGs, Sustainable Development Goal 3, health and well-being, and UHC is talking about UHC for all, coverage for all, so that no one is left behind. And we also have the WHA resolution on attaining the highest attainable standards of health for persons with disabilities in 2021, for which we all advocated at the global platform. And we have the political declaration of UHC in 2019, where it mentions about rare diseases. And so from here, how do we take it? How does it trickle to the country level? Yes, advocacy form a major part of the efforts to implement or ensure those policies are being brought in at the country level. In India, for example, I would say that we got the national policy for rare diseases in 2021. So is the policy great? It's not really great, but it is a good step forward, and it has given some relief to the community. And you can see that it is talking about treatment and funding, but it is also categorizing people into 3 categories. And the third category, who needs extensive medication or extensive treatment, which is more expensive, are being left to crowdfunding, and all these kind of matters evolve from the policy. So human rights cannot be categorized. So we cannot categorize people like this. And so we continue to advocate with our government. And the government is also taking steps on newborn screening, but again, the newborn screening is only taking place in certain states and not in all states. And sensitization is good after the policy, but still a long way to go to sensitize the doctors, the community on the rare diseases or the health information as such. It is not enough if you have things in the policy. It need to reach to the person at the ground level. That is when the person get information, the person gets empowered and can access services. So in that part, civil society has a major role to play, and we are doing that. And we have been advocating very strongly with our local government. And in Tamil Nadu, during the COVID time, we advocated with the disability department and the local implementing authority to vaccinate all persons with disabilities and rare diseases at their doorstep, because people cannot come out, and it is highly risky for them to come out and during the pandemic time, and people have to touch surfaces. So to avoid all those things, and the parents have to transport children from home to vaccination center. So we appeal to the government, and the government provided doorstep vaccination not only for people with disabilities and rare diseases, but also for the caregivers, the the family members. Yeah, so I will finish in a few minutes. Like, how many more minutes do I have?
Maybe a minute or two, Smitha, is that okay?
Oh, sorry. Yeah, okay. So,
Thank
a
you.
lot of advocacy happened, and towards funding, I will just quickly go into the funding part. We need funding from nutrition to across the life cycle, from nutrition to diagnosis and treatment or maintenance and personal care system. How a person with rare disease can have a supporter for doing their day-to-day activities and those things, and sensitization also. So everything trickled down to funding, and UHC is the only way. And rare disease should be a center part of the UHC policy and UHC financing. And government is basically the largest financier of public health systems. So we should give priority for rare disease in budgeting, and in social security budgeting we can have some funding, or we can tap the paramedical support, we can tap the academic and research institute who have funds. They can look into the research part of the rare disease, and the sensitization area has support, has funding. So we can look at different multiple segments where funding is available and tap in for rare diseases, instead of asking for from the health department for all the funding. And of course the health budget should be escalated, and it should be more. And apart from that, we should also look into the international funding, like the Gavi or the Financial Intermediary Fund, Global Fund. So these international funding agencies can also support the governments. And apart from that, the corporates, the CSR, corporate social responsibility should take some responsibility towards funding the rare disease community, towards different services of rare diseases, and the community development collective fund, which the government also agreed, when we went and met the health department. So these kind of collaborative effort need to be made. And finally, how do we do it? It won't happen without us tapping it. So we have different opportunities, and we have to create opportunities as civil society. And what we need to do is to push at the global level as well as at the country level. Yeah, I'm just finishing it. And right now we are going to have the UN high-level meeting on UHC 2023. So we have to take that opportunity to push and mobilize political support, and also to start with UHC key asks, and to reach the decision makers. So make rare disease center of UHC. So this is what should be our target, and it can be achieved only collectively. Thank you very much.
Thank you so much, Smitha. Thank you very, very much. I know we can keep talking about this for a while, but we do have to move on. And of course, financing for UHC really is kind of the key pillar, so to speak, of what we're speaking about. Speaking of key pillars, I'm going to call on my colleague, Flaminia. We're going to present, the two of us, for UHC for rare diseases, the key pillars from civil society. So I'm just going to share my screen, and Flaminia, you can take it away.
Thank you, Dolores, and good morning, good evening, everyone. So before going to the main pillars that will be presented by Dolores, let me very briefly present RDI and the process we are currently in towards a WHO resolution on UHC for rare diseases. Next, please.
Sorry, 1 second.
So Rare Diseases International is the global alliance of persons living with the rare disease and their families. And we currently have 86 members, which are themselves all umbrella organizations. And through our membership, we are actually active in more than 150 countries. Next, please. So talking about global political commitments that were mentioned by Todd Holland, what do we have now? So currently we have the political declaration on universal health coverage, within which there is a specific mention of rare diseases. We also have, since exactly 1 year, the UN resolution on addressing the challenges of persons living with the rare disease and their families, where there is very strong language on universal health coverage. And this UN resolution is holistic, addressing many different SDGs, including obviously SDG 3 on health. And this is the one that we are addressing with this campaign that RDI is coordinating and launching on a WHO resolution. And also we are working, and we will work more and more with other UN bodies linked with other SDGs and with the Office of the High Commissioner for Human Rights. Next, please. So the process towards a WHO resolution. What the RDI secretary, next please.
Sorry, I don't know why it's.
Oh, it doesn't matter. I can keep on
A little
talking.
bit here. We'll go like this.
Yes. So the RDI Secretariat developed a very first draft of which key pillars could be included in a WHO resolution. This first draft was based on the language, and actually, as I was saying, the pretty strong language on UHC within the UN resolution, but also on existing successful WHO resolutions, their structure, their language, how it's presented, etc. And obviously also on the knowledge gathered through RDI's membership. Next, please. Then this first draft was submitted twice, in September and at the beginning of December, to the RDI Policy Committee for input and revision. Next, please. The RDI Policy Committee includes 19 policy experts and advocates from all continents, from both national alliances and regional umbrella organizations, and also disease-specific international federations. The policy committee discussed and modified the first draft of the key pillars, the first time in September and again in December, last week actually. Next, please. After that, RDI launched a global survey, which is anonymous and publicly accessible. It is available in English, in Spanish, and anyone can respond from different areas of expertise, different backgrounds, and stakeholders group. So everyone was given the space to have a voice in this joint effort, and we have now 332 responses. You also were all invited to complete the survey when registering to this event, and the survey is still open until the end of the week. So don't hesitate, for those who didn't respond, to access it now via the QR code that is on the slide. Next, please. And finally, we also gathered the input from 3 regional conferences, meetings. So from the pre-conference workshop to the Aliber conference for Latin America, the annual conference of APARDO for Asia Pacific, and from the post-conference workshop for Africa. The feedback from Aliber and APARDO was discussed at the policy committee last Monday, and then the feedback from the African workshop was also collected and the key pillars were further elaborated. So now the key pillars that Dolores will present today have been actually finalized last week, and they're fresh from the press. Please, Dolores.
Yes, thank you so much, Flaminia. Yes, exactly. They're fresh from the press, hot off the press. So These are the 10 pillars. Here are 7 on this slide, and then I will show you 3 on the next slide. So a couple of caveats before I actually present them. Firstly, please keep in mind that these are really quite general and broad pillars. So when a resolution or a document of any kind will be written, we're going to actually add more details and more wording to each and every one of these ideas. So really, this is just kind of a concise summary of what we're trying to say with each ask, so to speak. So the first 7 pillars are directed towards WHO member states. So I saw in one of the comments that someone was actually reiterating that we need to actually check all 3 boxes of UHC. So that's the first pillar. We're calling on WHO member states to cover more persons living with a rare disease, with more services, and with lower OOPS or out-of-pocket expenditure. Secondly, we're asking member states to strengthen primary healthcare systems and referral pathway capacities. So of course, primary healthcare systems, primary healthcare caretakers are the sort of first instance that a person living with a rare disease can actually have with the healthcare system. So we really want to make sure that they're really strong in welcoming that person living with a rare disease to the healthcare system and passing them on to potentially experts or expert service teams. Of course, we need to take into account for example, the urban-rural divide in a country, how a primary healthcare system is specifically structured in a country. Of course, it can make a huge difference if you're living in a city or in a rural setting. Thirdly, we're calling on member states to promote holistic care, including the provision of psychosocial support and traditional healing methods for persons living with a rare disease and their families. Actually, this came up a few times in our workshops, especially the point about traditional healing methods, so we're happy it's in there. Fourthly, we're calling on member states to acknowledge the role of and also empower currently unpaid caregivers and local and social care practitioners to assist persons living with a rare disease. Next, we're calling on member states to, as Mr. Howland foreshadowed, include persons living with a rare disease and their families at every stage in policy development. We're calling on member states to optimize international research, collaboration, and data sharing. Potentially something that could be underneath this pillar is an operational description or some kind of systematized definition on the global level of what a rare disease is. Seventh, we're calling on WHO member states to support the networking of rare disease experts and expertise globally. So those are sort of the main key pillars directed towards member states. And of course, this doesn't exclude that potentially these actions could take part in conjunction with actions on the regional level, including regional bodies. So the last 3 pillars are directed towards the Director General of the World Health Organization. Their first ask would be to adopt a global strategy for rare diseases, as exists for other health issues, as you probably know, to include International Rare Disease Day, so the last day in February, the rarest day of the year, in the official UN calendar, and to call on the WHO DG to report on the implementation of this resolution on a biannual basis. So as we know, of course, it's great to sign a document, but we'd like to see some indicators and ways to actually measure success for this document. So that's where the pillars are right now. We're not quite finished with them just yet. We have a few more steps, including, as Flaminia said, the closing of the survey, which is coming up at the end of this week. So you still have a chance to complete that. We'd still like to organize a few regional workshops, mainly with Europe, North America, potentially Middle East, North Africa region, Central Asia, and the Caribbean region. And that would be happening in January of 2023. And then we'd have this document up for approval by the Policy Committee and by the RDI Council also in the first quarter of 2023. And with that, I thank you for your time and attention in this presentation. So, okay, we made up for some time. We're going to move on to the panel discussion now. So I'd like to call on all the panelists to please turn on their cameras if they haven't done so. And I think we can get started. Again, just to reiterate, you're very welcome to post a question in the chat, and we'll set aside hopefully some time to take a look at those questions. Okay, so KP, I'm going to start with you. You're well prepared. Cameras on, mics on. So KP, welcome. The Health Bureau of the government has, since 2021, supported the coordination and execution of the Hong Kong Genome Project, a genome sequencing project which focuses on undiagnosed diseases, hereditary cancers, and diseases related to genomics and precision health. KP, how do you see the value of this project for persons living with a rare disease in Hong Kong?
Okay, thanks for the question. And, you know, the Hong Kong Genome Project was pushed by the stakeholders over 2 decades, in past 2 decades. So we are happy to see that this project is now as a reality. And the Hong Kong government has input 1.2 billion Hong Kong dollars. That's about 150 million US into the project. Please note that this project is not only or totally for rare disease. Rare disease is just a part of this project. And that means the Hong Kong government is doing something to cope with rare disease, but not very focusing on that. As this genome project, you can see the Hong Kong government has no policy, has no definition, has no strategy, has no planning on rare disease yet. And so the patient organizations, the patient advocates in this years are pushing the government to think about comprehensively how the government can cope with the challenge of rare disease in Hong Kong under the universal health coverage umbrella. And I think this is still a long way to go. Even the Hong Kong is now pushing the Hong Kong Genome Project. But for rare disease, it is just a small part of this project. That's what I want to comment on Hong Kong Genome Project. Thank you.
Thank you, KP, and thank you for joining us late in the evening from Hong Kong. Very interesting, and you're really highlighting that we have quite a lot of work left to do. Roberta, you are joining us from Argentina. Roberta, a very recent academic application made the following remarks on the Argentinian healthcare system's provision of UHC. They wrote, Argentina metrics show that even with strong financial incentives and an increase in the pooling of funds, unmet healthcare needs persist, mainly in provinces that suffer a lack of healthcare providers. Do you agree with this statement, Roberta? Do you think that these factors are further aggravated for persons living with a rare disease?
Absolutely, yes. The publication that you mentioned is really very interesting. The initiative carried out by Argentina in the implementation of universal health coverage still have pending to reach vulnerable population, such as old people, others in poverty, levels or living in isolated rural areas, sexual minorities, and among which is also the population of people living with rare diseases. And this is related to the fact that many of the programs that are implemented for explicit drugs coverage do not include those required by rare diseases. Even more significant when we refer to therapeutic innovation in diseases where there was no treatment before, and also the lack of specialists and centers in rare diseases in places far from the big cities. Also, the pandemic showed that we are not totally prepared for digital health, as in many areas connectivity is a lack. In Argentina, we'll still have to design political measures that improve both the provision of services and financial protective mechanisms, with the aim of improving access to comprehensive care, reflecting the purpose of the universal health coverage for rare diseases. According to a survey that we did carried out by Alibert and Fadepov called En Serio LATAM Study Argentina chapter, 45% of families living with rare diseases allocate between 10 and 40% of the annual family income to the disease they suffer. A number above the data from the World Health Organization and the World Bank that determines that in Argentina, 5% of the population spend more than 25% of household expenses on health. So in the field of rare diseases, we think that it is essential that any strategy that is implemented must have a focus based on results that requires a roadmap in place with a robust governance, with clear roles and responsibility to ensure that healthcare is delivered equitable. Thank you.
Thank you, Roberta. Thank you so much. And it's interesting, you're bringing up kind of like an intersectional lens to your answer, right? That there are other parts of a person's identity that also need to be taken into account. Okay, so Samuel, over to you. I'd like to potentially maybe bring the conversation to a more regional level, but that's up to you. You actually practiced as a clinical psychologist in Ghana, and of course you later established the Rare Disease Ghana Initiative, the organization which you're representing here now. You've traveled extensively around Africa and the world, and you speak regularly about rare disease policies in this continent. What challenges do you see specific to the provision of mental health services as part of UHC for persons living with a rare disease in Ghana in particular, or potentially in Western Africa in general?
Thank you very much, Dolores, and greetings, everyone. Yeah, mental health is a critical and important part of rare disease, and as part of efforts to achieve UHC, it's necessary that we pay critical attention. I would answer my question from three main points. First of all, I see one of the biggest challenge has been even appreciating that the rare disease journey has a parallel mental health implication. And so many a times we talk about finding treatment and diagnosis, and we pay little attention to the mental health issues that are associated with the patient journey. And that is very, very necessary for us to think about it. On one angle, looking at the fact that some rare diseases may in themselves require mental health support, as the disease presents with mental health challenges as one. And then the other angle being the fact that many rare diseases also are compounded with a lot of uncertainties. The journey has a lot of uncertainties. And because of that, families have to always adjust from the first day they find the symptoms to finding specialist centers, to finding clinicians, to finding diagnosis, to treatment, to the whole process, how they even cope with the the disease. It brings a lot of mental health challenges and so if we don't come to terms, or if we don't, it's not conceptualized in the disease, rare diseases are not conceptualized together with the associated mental health impact, then the chances are that we will not make provision for support or care for persons living with rare disease in terms of how they can manage their mental health challenges. And so the other concern has to do with the service. I think generally mental health service provision is very poor and the coverage is very poor. The human resources are very limited across Africa, even in Ghana. So far we have about 35 psychiatrists and very few other mental health professionals available, and services are very, very limited. And so imagine dealing with mental health, having mental health challenges, and the general population cannot even access mental health. And then now you have a rare disease and you have to also seek mental health care, and it's still going to be the least because most of the professionals may not be well knowledgeable in the disease area to even be able to equip and adequately help you manage the disease. So that's also another angle that I see as a big challenge. The third one is the fact that the usage of mental health services also may be another challenge for families. And that's because in Africa, and specifically in Ghana, there's mental health is highly stigmatized, and rare diseases is equally stigmatized. And so if you have a rare disease and you have mental health challenges, it means that you're going to deal with a double stigma squared. And so it makes it more challenging for families to even go out there and seek services and support where needed. But there is a growing visiting patient groups, patient advocacy organizations doing more in the space across Africa, and has led to the space and have done a lot of work. And so that also brings some level of hope that we could capitalize or leverage on these resources as we work towards universal health coverage.
Thank you, Samuel. Thank you. Yeah, stigma squared. Imagine it's tough living with a rare disease and then mental health issues on top of it. Okay, Daria, over to you. You're representing two organizations today. Thank you so very much. One of your roles is as the scientific coordinator for the European Joint Program for Rare Diseases. This program works with 26 EU member states, but also 9 other European and global countries, including Canada, to, amongst other things, implement and further develop an efficient model of financial support for all types of research on rare diseases. What role, Daria, do you think can regional funding schemes have in supporting national UHC measures for persons living with a rare disease?
Thank you, Dolores, and thank you very much for giving me the opportunity to participate in the schemes. I, as you can see, I dressed in the colors of the conference. First of all, I think it's really extremely important to understand that actually within the multinational funding and within the support dedicated support scheme, sometimes it's really difficult to get engaged in funding of research, being it dedicated to healthcare, to social sciences and humanities, or to any other type of research related, let's say, to rare diseases. What we have noticed also is that very often actually there is no dedicated national funding for rare diseases, and the countries, when they need to make a choice, they decide to actually invest in this kind of multinational research funding programs for different reasons. So, for example, because of the fact that it gives the advantage of a already existing robust and high quality evaluation process that can be just picked up then and integrated. It means also, of course, that it opens the opportunities for collaboration. For example, at the level of the European Joint Program on Rare Diseases, as you mentioned, we do not have only the European countries, but we also go beyond, and we develop different dedicated support schemes. So first of all, I think what is important to remember is that by joining the forces and bringing your, let's say, small or big contribution, in any case, you are going to leverage on overall funding. Because, for example, country coming with, I don't know, 50,000 euros into a to finance their national component, at the end gives the opportunity to their national, let's say, research community to participate in a project that overall costs 1 million, 2 million euros. And that means that at the end, this would not be possible if it had to be funded only at national level, while it is possible when it is done in the multinational way. We also have some dedicated schemes or programs that allow, for example, what we call the widening. So it means that if your national, let's say, research community is not so yet well integrated or not so competitive, for example, in the multinational funding, it means that we can implement a dedicated schemes that we called widening, and, for example, allow the research teams from those let's say underrepresented countries to join the research projects that already went through the first step of the selection. So there are a lot of things that can be done when thinking about the multinational funding schemes and adaptation. So that's why it is so important to get involved. But I would say that the leverage of funding is not only for research itself, but also, for example, for the education, for the networking, where small amounts of money can be very helpful. And we implement programs that allow on the networking that can be, hopefully will be also expanded beyond also the, let's say, the European area, as well as dedicated education programs. And, for example, we developed massive online courses that are dedicated to the diagnosis of rare diseases. Recently, we have opened another one on the translational research, and that are open globally, and they are offered for free. So it means that we can also, in a way, kind of share the expertise, share the knowledge, even if it is funded, for example, from the, let's say, from the European funds. And finally, what I wanted to mention is that actually funding is not always the most important to be the one to obtain. And this is something we discussed a few days ago when we met with Samuel, for example, during the conference on clinical research network here in Paris, is that often what is the bottleneck is to bring the necessary expertise. So it means that we can find the different means of funding, but the expertise is not necessarily there, and so sharing the expertise is extremely important. And finally, also in relation to what Smita said, is that we can leverage on different types of already existing national resources. And often what we do not think of is what we call the in-kind contributions, which means that you already may have programs in which you invest nationally, and actually they can be brought as a connecting programs to some bigger initiatives that can then, from which you will be able to profit, and that can also profit from your own expertise that is being brought to those.
Thank you so much, Daria. That was a very comprehensive answer, and you actually went above and beyond the question and expanded our point of view. Yeah, very important to realize that funding schemes can actually be very flexible. KP, I want to bring it back to you. As you know, UHC is enshrined in the 1948 WHO Constitution, which declares health a fundamental human right, as again, Mr. Howland showed us, and commits to ensuring the highest attainable level of health for all. However, according to the WHO's Triple Billion Dashboard, which tracks the progress of countries towards UHC, on average in the Southeast Asia region, only 60.80% of services are covered under UHC, and in the Western Pacific region, where Hong Kong falls, that number is at around 69. Is Southeast Asia on track to cover all persons, including those living with a rare disease, under UHC by 2030?
Oh, this is a good question. You know, Hong Kong is a very wealthy economy, as well, I think most Southeast countries are upper middle income countries or even higher. However, the figures you quoted are really not satisfied. And I think the economic development level in these countries cannot match with the UHC level. And I think in particular, the rare disease would be the underdeveloped area in the healthcare system. That means universal health coverage. The most ununiversal is now in the part of rare disease in most countries. And so if you talk about 2030, I am not so optimistic. And of course, there are much works to be done. And I think to push universal health coverage, in particular for rare disease, is the important task for patient organizations in this region. What we advocate in Hong Kong is tripartite collaborations. That means the government, the business sector, and the community works together to cope with the challenge of rare disease. Of course, the collaboration should be headed by the state government. So I hope in Hong Kong and in Asia Pacific region, in most countries can have this kind of collaborations in coming years to raise up the level of UHC by 2030, even it is not higher than 90% or so. And that's my hope exactly. Thank you.
Thank you, KP. Yeah, we're all hoping that a lot's going to happen in 7 years. Roberta, you are a tireless advocate for persons living with a rare disease in South America and actually also globally, as you sit on RDI's policy committee, and you recently led a South American workshop on UHC for persons living with a rare disease. Roberta, often enough, we meet people who actually potentially aren't even fully aware of the elements of their social healthcare protection system that they are entitled to. Do you think that persons living with a rare disease in your region are fully educated on what rights they do have in their national healthcare system? Do you think education on this matter has to be increased?
Well, you know, in our region, we don't have a reimbursement plan, but we have law or different other specific coverage systems. Usually people do not know their rights related to health in general, but more when they face a new health condition as rare diseases. So therefore, the education, the dissemination of general and specific health law is a fundamental task to help the community. This is a task that we must carry out permanently and constantly as civil society in order to help our community. In LATAM, certain countries have rare diseases standards. Those that do not have should continue working to get it, but along the way, they must rely on those already existing locally, as well as international political treaties and declarations, as is in the case of the resolution of universal health coverage and rare diseases of December 2021. Under the United Nations high-level political meeting declaration on universal health coverage, member states promised to invest in extending their health services to cover more of their population, enhance their primary healthcare services packages by including comprehensive and innovative services and reduce the out-of-pocket costs for patients living with rare diseases. So As a rare disease community in the LATAM region, we need to insist and fight for this to be fulfilled, as it is our duty. Hence, the importance of this global initiative that can be very useful at the local levels and working together throughout the region to strengthen links, to share good practices and local needs. So all the RDI initiative resources and toolkits of different material help us and reinforce our work both locally and regionally. A good example, as you mentioned before, was the last webinar we did from the LATAM region in Spanish about the WHO resolution key ask in order to discuss all together each point. And this kind of work is really a great opportunity to get all the voices of everyone as a rare disease community. Thank you.
Thank you so much, Roberta. Daria, you are also the coordinator of IRDIRC, or the International Rare Diseases Research Consortium, in its secretariat. Our global survey showed that international research collaboration is one of the most prized elements of UHC for persons living with a rare disease globally. For you, what does international research say for UHC for persons living with a rare disease? How does it fit into UHC? What is its value? Perhaps you could draw on past examples. Thank you.
Thank you. So I would just like to clarify that I'm the coordinator of the scientific secretariat of the International Rare Disease Research Consortium, and that the chair of IRDIRC so I'm not the chair or the vice chair of IRDIRC, just to clarify this. In relation to the importance of the international collaboration, well, first of all, I think, and this is I think still too often forgotten, that there is no healthcare without research. For us, you know, there is this kind of like a seamless border between the research and healthcare. And especially when you think, for example, about the diagnosis, we say, and this is also one of the goals of IRDIRC, that we say that patients should be diagnosed within 1 year of coming to medical attention, or be integrated into the research pipeline if they are undiagnosed. And this is extremely important, because indeed research is an integrative part of healthcare. And when we think in terms of the international collaboration, I think that IRDIRC indeed is a place where all those international efforts are being translated into the very tangible outcomes. So as you may know, IRDIRC works in a way that we organize the so-called task forces. We're bringing the experts from all over the world, from all different types, let's say, of stakeholders, to make sure that we can tackle important issues and bottlenecks. And so just a few examples of what has been produced as outputs of this kind of international collaboration. When we think about, for example, social sciences, humanities, there was a dedicated working group that worked on this, that kind of mapped what are the funding programs in different countries, in different regions for those social sciences and humanities, and the fact that actually this kind of collaboration and support for research is missing. And as an output of, or the recommendation was that this should be better targeted. And so within the European Joint Programme on Rare Diseases, we were able to set up a dedicated call for multinational research projects in social sciences and humanities. And it was actually the first time when this kind of multinational research projects that now are running and are tackling those different aspects. And we were talking about the fact, you know, that it is important to, for example, evaluate if the current system conforms the human rights, how the persons living with rare diseases can participate actively in policy making, how the technical know-how and training of physicians is impacting your national healthcare systems. So all these aspects indeed are also part of the research. We need to demonstrate also what is happening at different levels. So that's why it is so important to always keep in mind that the social sciences and humanities must be part of the research at different levels. Other things that are being implemented at IRDIRC For example, there was a dedicated task force that worked on the methodologies for clinical trials or improving the clinical trials in small populations. Again, this has been, some recommendations were issued, and this has been translated into the development of the dedicated methodologies that currently we are validating through a research project, and that we hope also by working with the regulators that we will be able to demonstrate their validate them, and so that in that case, we can improve the implementation of the clinical trials in small populations. Other things that are currently running and are international efforts by PLWRD is, for example, how can we again improve the development of the therapies for rare diseases when we know that, let's say, the traditional business model for the development of the therapies does not work when we think about the ultra rare diseases or the small populations. So we focus, for example, on the shared molecular etiologies, that where we try to demonstrate that it is possible to find some commonalities, and it means between the rare diseases, and it means that we can tackle them in that way. So how to develop therapies for multiple rare diseases at the same time. We have dedicated so-called recognized resources that PLWRD is recognizing as an important element, and you can find all the list. And again, they are freely accessible to everybody. We have the Orphan Drug Development Guidebook. There are so many things that can be developed through the international collaboration. And maybe I would like to just finish that, as I mentioned last week, 10 days ago, we had a meeting in Paris where for the first time we met and we brought together different stakeholders from the clinical research networks from all over the world, because it was considered that it is extremely important to try to connect. And of course, the global rare diseases networks were also, or the concept of the global rare disease networks was also presented there. And so I think that, yeah, bringing together the different stakeholders, it means knowledge sharing, and it means also the capacity sharing and helping into advancing into the collaboration.
Thank you, Daria. Thank you so much. Yes, indeed, a very fruitful meeting you had in Paris, and thank you for bringing up social sciences too when we speak about international research, of course. Okay, Samuel, we're going to end with you. Hopefully, you won't speak for too long, and we'll have time for questions other than those just from myself. I would like to try at least to end on a positive note. It seems that although a lot has happened, there is still quite a bit left to do until UHC for PLWRD is a global reality. What are some actions that you see patient advocates in Ghana, potentially specifically, or in West Africa, I say again, generally, doing right now, which you believe are helping get persons living with a rare disease that much closer to UHC by 2030?
Yeah, thank you. Thank you once again. What is happening in Ghana and in many African countries is a demonstration that patient groups are capable if supported. And that's what we have seen from patient groups and patient organization leading in awareness creation to connecting or building research, clinical research networks, to developing initiatives around diagnostics or developing initiatives around treatment, access to treatment, to advocating to policymakers to take action on rare diseases. But not just that, but we have also seen patient groups also connect at the regional level and build into alliance. And just about 2 to 3 weeks ago, we met in Kigali to establish the Africa Rare Disease Alliance, which is something that is moving, which is coming up and doing very well with towards a regional level advocacy. So as we work towards universal health coverage, what is being shown is that patient groups can also help to achieve this, can help to drive this front. And so policymakers and decision makers should be very open to support these efforts. In Ghana specifically, I've seen patient groups come in to provide emotional support and strengthen disease-specific groups who coordinate and help, even mobilize resources to help those who cannot access healthcare to get that level of access. And so rare disease care is not insured, but you see that through the patient support groups and patient advocacy groups that are here, there's a level of access that is provided for some families who could not afford to get access to healthcare. And so in that same way, that this model could be studied and could be possibly replicated in areas and regions where governments may not be ready, or the systems may not be right, or infrastructure may not be available, and it can be very, very useful. And that's what I see happening in Ghana and Africa.
Thank you so much, Samuel. Yes, indeed, I heard from other patient advocates that the Kigali conference went very well. So congratulations, Africa Rare Disease Alliance. Okay, I think we actually have a few minutes for a question or two to the panelists. I see, KP, that there is a question directed towards you. They're asking what other diseases are listed in the Hong Kong Genome Project by the government other than rare diseases?
Okay, the project listed a number of cancer and also some common diseases like the diabetes and hypertension, because the government wants to identify the genomic issues of the Hong Kong people for genomic medicine in the future. So rare disease is just, as I think, a small part in this project.
Thank you so much, KP. Thank you. And maybe one more question. Roberta, I see that there is a question directed towards you. Are there any collaborative programs for rare diseases in Latin America?
No, if you refer a collaborative fund, for example, we don't have any collaborative program here in Argentina. That's why we need a roadmap to work together. That is part of our work in the federation to insist to the Minister of Health. But we have a registry, we have a committee, but we don't have now a strategic plan. And there is also different diseases that are in the list, the national list of rare diseases, but we still have a lot to do, but we are trying to do our best as a community.
Yes, indeed. Okay. Okay, well, with that, I think we can end our panel discussion. I want to thank very much all of the panelists and actually all of the speakers before them. I think with that, I'm going to give the floor over to Durhan Wong Rieger, the chair of the RDI Council. Thank you to everyone again.
Wow, thank you very, very much. And certainly huge thanks to Dolores for shepherding us through this very, very ambitious and very, very informative agenda. I will have to say, I have no idea why I even agreed to try to provide comments at the very end of 85 minutes of such stimulating discussion. And I will not impose on anyone by trying to summarize what we heard. What I do want to say is maybe a bit of summary, but really point this to, I think, what Flaminia and Dolores is talking about is where do we need to go? Certainly, I think as Dolores acknowledged, and certainly as we heard from all the panelists, we got a long way to go. We've got the, UN Declaration on Universal Health Coverage, and obviously getting rare diseases in there was something that we worked very hard for because we believe it was necessary. And what we heard from everyone, starting from Mr. Holland, down, we really recognize that having that in there because rare diseases was and still is a under-resourced, under-recognized, disadvantaged population that was so very important. And as we got with the UN resolution, the acknowledgement that rare diseases affects certainly a whole lot more than just clinical outcomes, but including, I think as everybody's touched on here, the other areas in terms of social, economic, educational, occupational, mental health, and certainly human rights. This was hugely important. But it is one thing to have high-level policies. It's one thing to have countries that are brought into acknowledging and agreeing to support them. It's another thing to get them implemented. And I think what we're hearing is that, and I was very pleased to see, especially from people like Roberta, that having toolkits, having these policies, but the opportunity to bring them to people and the opportunity to have dialogue on them and what we're going to do to actually implement them was hugely important. So, I mean, huge thanks to Roberta and her colleagues and all those others that have been hosting these sessions for making that happen. And we also heard, I mean, obviously importantly from, people like Samuel, that it really takes work from the ground up and a lot of work from individuals, from leaders, from patient advocacy groups, from clinical groups on the ground up to make this happen. And certainly as we heard from Sarah Cothman, it really also takes the healthcare professionals working in the middle to make this happen. Having the global policies, having national buy-in to it really helps a great deal, but it isn't going to be sufficient. I think what Mr. Holland said at the very beginning is our challenge. We're a long ways from not only universal health coverage, but we're a long way from having rare diseases fully recognized in that. Certainly, I think as Daria indicated, not just in the research area, but the collaborative initiatives are really important. So what we're doing collaborating is very important. But more than that, I will add here what I really hope that we can do in this next iteration is to really make the value case for it. It's not enough to say ethically. It's not enough to say morally. It's not enough to say there is, in fact, an imperative to do it. We've got to drive home that bringing and addressing rare diseases has huge economic benefits and huge economic repercussions when we don't. And one of the things Samuel didn't talk about is one of the lessons I certainly learned from him, and that is when you put the economic package together and you show what not diagnosing, what not providing care to persons with rare diseases does to your health system in terms of recidivism, in terms of repeated entries, absolutely has a huge impact. So I think we need to be a little bit, I will say, maybe I say smarter in the rare diseases environment. We need to make sure that we get the economic message out there as well. I mean, and picking up a bit of what Daria says, how do we coordinate? How do we coalesce these resources across regions to actually make it happen? I just came back from, Bangkok, where I was blown away, and Dolores, you were there as well. And certainly Sarakna was there, really letting us know how much work is going on in each one of those countries, but not nearly enough happening in order to coordinate, collaborate, to build on each other's resources. So there's a roadmap that we have to think about. I'm happy to hear the African Summit went well. The question is, can we make that click? Also just came back from Brazil, where I was at the opening of the Porto dos Rares, the House of Rare in Porto Alegre in Brazil. Absolutely stunning whole house, institute for diagnosis, for care, for treatment for patients with rare diseases that was built from the ground up by volunteers, by funders, by sponsors. But what it's also done is spawn huge amount of state support in that state for rare diseases. And their projection for a Casa Hunter hospital in Sao Paulo is going to help as well. So we see what happens, ground up, dedicated individuals, a lot of times family members, dedicated healthcare professionals working together. But I think Daria really hit it for us very strongly. We've got to collaborate. We've got to coordinate. We've got to be able to build on each other's resources. So RDI, I think we're trying to do a whole lot at the global level. Hopefully at the regional level, we can help stimulate the regional alliances to really be able to work better together. And Roberta, I think you and I will agree that part of it is trying to overcome political differences and petty jealousies among the players there. We've got to do this. But we also need the funding. We need the support so we can make that happen. This has been a tremendous opportunity. I think it points us, as Dolores and Flaminia laid out, towards the WHO resolution on rare diseases, but it also points to the huge amount of work that we all need to do together. We're definitely the community to do it. I don't know any other community that works as well as the rare disease community, but we've got a long ways to go, and we definitely need all the support from every level. So thank you again so very much.
Thank you, Durhan. And I think with that, we will close this event. Thank you, everyone, so very much, and happy UHC Day. Bye.
Bye-bye. Thank you.
Bye-bye. Thank you.